Okay, I think we're at 2 p.m. Eastern, so why don't we go ahead and get started. Hello, everyone. My name is Deborah Shelton, and I am the medical liaison for the ACPMP Research Foundation. And by way of reminder, the Research Foundation is a nonprofit 501c3 volunteer, largely volunteer-driven organization. Our mission is to fund promising research to find a cure for ACPMP and peritoneal surface malignancies, and to fund educational programs for physicians and patients about these diseases. And that is what brings us here today. We are very fortunate to have as our guest speaker this afternoon, Dr. Holowatyj. And Dr. Holowatyj is an assistant professor of medicine and cancer biology at the Vanderbilt University Medical Center and Vanderbilt Ingram Cancer Center. Dr. Holowatyj obtained her PhD in medicine cancer biology at the Wayne State University School of Medicine and Karmanos Cancer Institute as a Susan G. Komen Graduate Training in Disparities Research Fellow. She then became an NIH postdoc fellow in genomic medicine and also did a postdoc fellowship at the Huntsman Cancer Institute at the University of Utah, and that was in cancer research. Now, at Vanderbilt, Dr. Holowatyj's research program and laboratory is centered upon the rising burden of gastrointestinal cancers, including appendix cancer among young patients. And it's interesting, her research is focused on uniquely synergizing epidemiologic and basic sciences laboratory approaches. Dr. Holowatyj will be talking to us today about appendix cancer in young adults, a distinct disease burden. And before I turn this over to Dr. Holowatyj, I just wanted to say that we received many questions as part of our pre-registration process, which we very much appreciate. And we are also open to receiving any additional questions that you may have as Dr. Holowatyj is presenting. If you'd like to submit a question, you may do so on the bottom there of your screen. If you scan across, you'll see the Q&A button, and you could type in your question. Dr. Holowatyj is excellent and all about trying to answer as many questions as she can. But that said, we may just have only a few minutes at the end. So I will not take up any more of those precious minutes. And instead, I will just hand it over to Dr. Holowatyj. Thank you.
Well, thank you, Deb, for the lovely introduction, much too kind. And it's really a pleasure to have the opportunity to speak about some of the work that my team has been doing over the last year, specifically focused on the burden of appendix cancer among young individuals. I think, as Deb said, more than happy to take questions throughout the process, and I've tried to incorporate answers to some of the fantastic questions we received with the registrations, and look forward to kind of having a dialogue and discussion after the talk. So just to give you a brief outline of what to anticipate in the next 45 minutes or so, I do want to start with a brief background on appendix cancer, and specifically the term we coined as early onset disease, and then highlight 3 of our studies that have really defined or have started to define a distinct burden of early onset appendix cancer, including both clinical demographic features, biological patterns, and health disparities within this population, and really land on the future directions for our ongoing research and where we hope to go and the questions that we hope to answer moving forward. So, to give you a little bit of background, although I'm sure many of you are well versed in this, rare cancers account for about 25% of newly diagnosed cancer cases each year and also account for 25% of all cancer deaths. However, given the rarity of these malignancies, including appendix cancer, we're presented with unique challenges in understanding disease pathogenesis, what's kind of causing the development of appendix cancer, and in developing clinical guidelines specifically for the treatment of these malignancies. Of course, appendiceal cancer is one of these rare tumor types, is a rare digestive system tumor. Essentially, it accounts for appendix cancer and other rare digestive system tumors account for less than 2.5% of all new cancer cases of the digestive system every year. And to put that further in perspective, the age-adjusted incidence rates of appendix cancer are about 0.12 per million person years, bringing with it unique challenges in the study of this malignancy and in being able to garner paradigm shifting discoveries that benefit patients. So, one of the striking things that my team initially observed with our interest in the burden of gastrointestinal cancers among young patients was a study published in early 2020 that demonstrated that the incidence rates for appendiceal adenocarcinomas have increased 232% between 2000 and 2016. You're seeing that here on the screen for both Canada as well as the United States. But one of the things I draw your attention to here is particularly these groups that are under age 50 years, where we see a steady annual percentage change increasing over all of these years. And we see some interesting patterns among particularly older patients. But with our interest in this striking observation that we're continuing to see an increasing burden of appendix cancer among young individuals, both in appendiceal adenocarcinomas, as I'm showing you here, but also paralleled in neuroendocrine tumors of the appendix, it really drew us to ask some questions about what potentially may be driving this rising burden of disease and better understanding potentially a unique population of patients diagnosed with appendix cancer before age 50 years. And so, as we continue to explore the literature, it became really clear that the causes that underlie this rising burden of appendix cancer, including that among individuals younger than age 50 years, which is what we define as early onset disease, remain unexplained. In that study, where I previously showed the graph, one of the things that they also demonstrated is that the rates of appendectomies actually remained stable over this time period. Why that's significant is because it tells us that the increase in the incidence of appendiceal tumors is actually not related to an increase in the number of incidental findings on appendectomy. So the majority of appendiceal cancers are actually diagnosed during appendectomy. And so that really led us to ask, with reasons unknown as to what may be driving this increasing disease burden, led my team to ask, does appendix cancer in young patients considered under age 50 years at diagnosis harbor a distinct disease burden? And that's really where we decided to establish the field of early onset appendix cancer and begin to explore potentially this distinct disease burden. And so I want to first start with the first question that we asked, and that was really, are there distinct patterns of appendix cancer among young patients with regard to clinical and demographic characteristics? To address this question, we used the SEER18 incidence dataset, which comes to us from the National Institutes of Health and National Cancer Institute. This is a population-based cancer registry, which means, as illustrated in the figure, there are SEER sites in each of the highlighted regions and states, partly selected to overrepresent diverse population subgroups, but overall amassing to account for about a third of the United United States population, making it somewhat representative of the population as a whole in our inquiry. And so we identified just over 8,800 individuals who were aged 20 years and older at a first primary diagnosis of appendix cancer over a 10-year study period. And so what I'm showing you here is the breakdown of these 8,851 patients by age of appendiceal cancer onset. As I mentioned, we defined and created early onset to be younger than age 50 years, compared with late onset, age 50 years and older. And the first thing that was really striking to us was the proportion of adults that were diagnosed with appendix cancer younger than age 50 years. Our discovery that approximately a third of all appendiceal cancer cases over a 10-year study period were diagnosed before age 50 years was striking, in part to put this in perspective, in that among individuals diagnosed with colorectal cancer, which my group does quite a bit of work in, we see about 1 in every 10 adults diagnosed with colorectal cancer before age 50 years. So this higher proportion of cases where 1 in every 3 adults diagnosed with appendix cancer is younger than age 50 years was quite striking to us initially. I also want to draw your attention to a couple additional demographic characteristics in this table, and that is, as I'll show you in the next slides, we see some interesting differences in the proportions of race ethnicity across these two groups, as well as by sex and clinical features as well. And so first I kind of want to show you a simplified stacked bar chart that really demonstrates these unique trends that we see in appendix cancer by age at diagnosis. So just to kind of orient you to this figure, as you'll see another one in the next slide, here's just the proportion of the entire population that falls within each age group, such that they all add up to 100. And you're looking at binned groups of patients by 5-year age ranges. And the legend for the colors here by race and ethnicity is on the right. And what you can really see simply is you see some distinct color patterns and changes in the racial ethnic breakdown of appendix cancer patients by age. In particular, overall, we see that 1 in every 10 appendix cancer patients is non-Hispanic, Black, or Hispanic. And what I want to draw your attention to is the red bars, where you can see that the proportion of the red bar actually increases with younger age. That represents the Hispanic population, where we see that the proportion of Hispanics is actually higher in younger age groups. And similarly, the purple stacked bars are American Indian and Alaska Native individuals, and you can somewhat minimally see a higher proportion of these patients in younger age groups. Although I do want to disclaim that the number of American Indian and Alaska Native cases is quite a bit smaller than other population groups. So we need to strive not to over extrapolate those findings from this study. In addition to looking at some of the demographic characteristics like I've highlighted on race and ethnicity, we also wanted to look at patterns based on clinical features, which included histology, grade, and tumor stage. For the purposes of this talk, I'm going to present the figure on tumor histology. So I think this is a really important characteristic in appendix cancer, and will also carry throughout the additional slides that I'm going to present. But here, once again, you can see marked differences in histological patterns among appendix cancer patients by age at disease onset. In particular, what you may notice instantly is this striking higher proportion of younger individuals who are who have carcinoid tumors, which are represented in blue, and somewhat so goblet cell carcinoid tumors, which are represented in red. And when you put the red and blue together, those two histological subtypes are what we consider neuroendocrine tumors, or NETs. And so you can largely see that among among younger patients, a significantly higher proportion of cases is diagnosed with neuroendocrine tumors compared with cases diagnosed at later ages who have larger proportions of epithelial cell tumors. And so, overall, as an entire cohort, we see just about over 40% of patients diagnosed with NETs of the appendix. And as I just mentioned, we see that epithelial tumors of the appendix actually have increasing trends by age. Here, we see smaller proportions of those tumor types represented among the subgroup of individuals at younger ages. So we went on to do some multivariable logistic regression modeling, which tells us a little bit about the likelihood of appendix cancer cases diagnosed before age 50 years to have certain features or to be less likely to have certain features, accounting for factors that we know could influence these associations, including patient sex, race, ethnicity, stage, insurance status, and tumor grade as appropriate. And I'm just showing you a snippet of our findings here. But I kind of want to, instead of just showing the table, walk you through some of the meaningful interpretations of our observations. So first and foremost, we observed among all patients put together as a group in this study that individuals diagnosed with early onset appendix cancer were actually 82% more likely to be Hispanic, which is a bit aligned with the changing demographics of the United States population as a whole. We also see that young individuals with appendiceal malignancies are fourfold more likely to be American Indian or Alaska Native. However, young individuals or patients with early onset appendix cancer are actually less likely to be diagnosed with high grade tumors. You can see that consistently for grades 2 through 4 in this case. So young patients are more likely to present with well-differentiated tumors. And young patients were also 2 to 3.5 fold more likely to be diagnosed with neuroendocrine tumors, again, comprising both carcinoid and goblet cell carcinoid histological subtypes here, which was interesting for us to observe. And so we actually wanted to go on a little bit, and given the importance of histology and appendiceal cancer, we wanted to tease apart potential patterns between epithelial tumors or adenocarcinomas and neuroendocrine tumors. So I'm going to show you the results of our associations and modeling looking with neuroendocrine tumors in particular for the sake of time, which is illustrated in this slide and this table here. Again, just walking through some of the important observations that we noted. So particularly among patients with neuroendocrine tumors of the appendix and compared with individuals aged 50 years and older at diagnosis, we see that young patients consistently, again, are more likely to be Hispanic. We actually see they're less likely to be diagnosed with advanced stage disease. As shown here, you can see young patient is actually 59% less likely to be diagnosed with a stage 4 neuroendocrine tumor of the appendix compared with older onset cases. Of interest and clinical relevance, we see that young individuals are actually 45 to 61% less likely to be diagnosed with high-grade tumors, defined as grades 3 through 4. We also see that they're 24% less likely to be diagnosed with goblet cell carcinoid tumors in particular. So kind of what it overall is telling us was we're seeing this shift in young patients towards well-differentiated neuroendocrine tumors of the appendix compared with late onset cases. Overall, some conclusions that we can draw from this study, again, this unique burden of appendix cancer in young patients where 1/3 of every of the patient population is younger than age 50 years at diagnosis. And we've kind of shed some initial light on distinct histologic and demographic features associated with early onset appendix cancer. And kind of continuing down this avenue of research and study, early onset appendix cancer determinants can help us to inform the discovery of risk factors and biomarkers, particularly among young patients, that carries implications for disease prevention, detection, and treatment. I know we received some questions about early detection and potential methods for prevention of disease. But until we understand more of the risk factor profile and patient groups who are more likely to be diagnosed with appendix cancer, particularly at younger ages, we're unable to really start to kind of to put into place early detection and any sort of screening program overall, as you may see for other cancer types. I do want to also address that because this study, as well as one that comes later, uses population-based cancer registry data, you may really note the lack of individual level features that are presented in this study. What I mean by that is individual health behaviors such as obesity, dietary factors, family history of cancer, or specifically appendix cancer, etc., as those are variables that are actually not able to be collected in SEER or in this data set. And so while this sheds initial light using a really large population that is representative of the United States population on some of these unique patterns of appendix cancer among young patients, it really also emphasizes the need for further research to better understand some of those individual level factors and how those may contribute to disease risk and outcomes. But after kind of identifying these distinct distinct clinical and demographic patterns, the next question that we really thought about instinctively is, well, if we're seeing distinct clinical and demographic patterns, do we see a distinct biology of appendix cancer among young patients? And to address this question as best we could using data that's currently available, we turned to AACR, the American Association for Cancer Research Project Genie Consortium, which collects clinical grade targeted sequencing data and demographics from individuals diagnosed across multiple cancer types at various institutions worldwide. In leveraging this unique data set, we were able to identify 385 pathologically confirmed appendix cancer cases who were age 18 years and older at clinical sequencing across 12 institutions worldwide. And for our inclusion criteria in this study, we wanted to ensure that they had both clinical data as well as sequencing data available to be able to account for some of those factors that we mentioned in the previous study. And so here I'm showing you the table of our population breakdown overall. And again, I just want to kind of point out a couple interesting points to consider as we move forward in talking about this study. And that's the observation that, similar to our findings in the previous study, we see about a third of appendix cancer patients in this data set present with early onset disease compared with late onset cases. The thing I want to draw your attention to importantly as we move forward in showing you the results is that across these two populations with the early onset and late onset cases, we actually don't see substantial differences in the proportions of sex, histological subtype, or sample type based on information available from Genie that allows us to really tease apart the potential biological differences in this study. We do see a higher proportion of Black individuals comprise the early onset appendix cancer population compared with late onset cases, as well as Asian or Pacific Islander individuals, although just to consider moving forward. And so the figure I'm showing you here is really the frequency of altered genes that we were able to look at and assess in our genomic landscape of appendix cancer by age. And a couple things I want to point out here is consistent with previous studies that have actually looked at the genomics of appendix cancer among all individuals and not considering age-related patterns. We consistently see that over half of all appendiceal tumors had a non-silent KRAS mutation, as represented in this bar in the figure. And we also see the TP53 and GNAS mutation and GNAS were actually altered in more than 1/4 of cases in our cohort. You can see here boxed or highlighted in the figure some of the most commonly altered genes out of the ones we were able to assess. I do want to point out this is a targeted clinical grade sequencing data set, which means that some of these panels assess about 40 to 200 known cancer-related somatic cancer gene variations. So we're not doing this on a genome-wide scale using this available data set. And so these are the frequently altered genes we see based on the data we have available. And so the thing I want to really draw your attention to here is when we teased apart that figure and looked at the frequency of somatic variations in early onset cancers, which is in the panel up on the top, versus late onset appendix cancers, which is in the panel on the bottom, we see a distinct spectrum of somatic variations emerge. And I want to kind of draw your attention to two really striking observations. And the first one is GNAS, where approximately 30% of all late onset appendix cancer cases had a GNAS mutation in their tumor. We see a strikingly lower proportion of early onset cases have a GNAS mutation in their tumor. So we're looking at 29% versus 19% of cases presenting with this somatic variation. And in contrast, we see that while approximately 1 in every 8 individuals diagnosed with appendix cancer before age 50 years has a PIK3CA somatic variation in their tumor, we see only 4% of late onset cases harbor a PIK3CA somatic variation, which is very striking, and I'll contextualize in a moment. And so we also did some modeling here to understand the odds of presenting with a somatic cancer gene variation by age group. And we accounted in these models for the role that sex, race, ethnicity, histology, where the sequencing was done, and the type of sample that was sequenced may play in this association. And after accounting for these factors, we see some interesting associations persist along the lines of what I presented in the previous slide. And that's that we see that young patients actually have a 60% decreased odds of presenting with a non-silent GNAS mutation. And in contrast, we see that young patients have a 4-fold increased odds of presenting with a non-silent PIK3CA mutation. We also see increased odds for young individuals for presenting with TSC2 and SMAD3 mutations in their tumor compared with late onset cases. PIK3CA is of particular interest given that there is an FDA-approved drug targeting PIK3CA mutations in a specific subpopulation of breast cancer patients. So this really opens up an avenue or potential promising potential to consider and to do laboratory-based investigations. First, of course, the potential for repurposing some existing cancer drugs in other cancer type contexts. And with the increased proportion of young patients that are presenting with a non-silent PIK3CA somatic variation, it warrants further study to discern whether that may potentially be clinically actionable, particularly for the early onset appendix cancer population. And so I want to just emphasize our findings because we wanted to tease this apart a little more and take a look at the patterns between individuals under age 50 years and those across older age groups in 10-year bins. And you can see The baseline mutation probability just increases by age group pretty consistently for GNAS. Again, young patients are have lower odds of presenting with a GNAS variation, and you see the opposite patterns for PIK3CA mutations overall in the big picture. And that's supported by our additional analysis of comparing individuals younger than age 50 to those age 70 and older, where we see again that young patients have reduced odds of presenting with the GNAS mutation, but increased odds of presenting with the PIK3CA variation, really just emphasizing and confirming our findings between early and late onset across additional age groups. So I do want to draw, really importantly, some limitations of this study and really where we are hoping that future studies can start to fill this gap with funding. So the use of ACR Project Genie data was an incredible resource that allowed us to identify pathologically verified cases with sequencing data from various institutions worldwide. However, Genie does not make available information on individual cancer stage, metastasis sites, PMP, tumor grade, or survival, which are all important factors to consider in the context of appendix cancer. And although we accounted for primary sample type, whether the primary tumor metastasis site was sequenced, molecular patterns in the study can still be in part related to appendix cancer stage. Not all somatic variations that we presented were systematically evaluated within Genie, given that this data is compiled from a dozen institutions worldwide, suggesting that the true prevalence of mutations that we see may be even higher than those that we've reported on. And again, the lack of data regarding individual level characteristics. Genie does not provide age at diagnosis, and so age is reflective of the age at clinical sequencing, which was the closest proxy we were able to use. However, those age patterns across multiple age groups really reinforced our consistent findings overall. However, notwithstanding those limitations, the conclusions that we're able to draw is that we have established a distinct genomic landscape of early onset appendix cancer, with younger patients having higher odds of presenting with somatic cancer gene variations in PIK3CA, SMAD3, and TSC2, and decreased odds of presenting with GNAS mutations in the tumor. This is the first evidence to suggest that appendiceal cancers diagnosed among young patients may harbor a distinct molecular phenotype versus late onset cases, and could, over time, as I've mentioned, yield some clinical actionability in the development and testing of personalized therapies specific for young appendix cancer patients. And so the next question that really arose after discerning that there is a distinct disease burden of appendix cancer among young patients is the question of heterogeneity within this population. So with our creating the definition of early onset appendix cancer as individuals diagnosed before age 50 years, based on and allowing us to compare early onset disease across other gastrointestinal tumors. One of the things that my team has constantly sought to emphasize in various research studies is that there's a lot of diversity within this population group. And so we also sought to ask, do disparities persist within the population of early onset appendix cancers? And so I just briefly want to address and kind of outline the complexity and the interrelatedness of factors that can contribute to distinct biology and potential disparities, or that contribute to carcinogenesis overall. And that's highlighted a bit in this simplified figure. But determinants of individual cancer risk and survival are a combination of complex factors that are biological and genetic, that are environmental and social, that incorporate health behaviors and individual level factors, and that also yield to a systemic and institutional level. And you can see that illustrated here. At the heart of all of these other factors is biology and genetics. You can see that, individual factors from health behaviors, sex, race, and ethnicity can contribute to biology and genetics overall, including gene-environment interactions. And then you have the built environment, which includes your environmental factors, systemic racism, geographic region, the family microbiome, your community health behaviors, neighborhoods, etc. And that built environment can also interplay with individual factors and, of course, biology and genetics. And all of that is really encompassed in the systemic and institutional level with healthcare systems, policy, and quality of care. So there is this complex interrelated factors that could be contributing to cancer health disparities, both overall and also in the context of this talk in early onset appendix cancer. And so what we wanted to do is take a look at heterogeneity by race and ethnicity within the population of early onset appendix cancer patients. So this entire study that I'm about to present to you, the entire population is all individuals diagnosed with appendix cancer before age 50 years. Again, we relied on SEER population-based cancer registry data for this study to be able to ascertain sufficient cases. And we identified 1,652 cases aged 20 to 49 years at appendix cancer diagnosis, diagnosed between 2000 and 2011. And the reason that we use the cutoff of 2011 here is to give us sufficient 5-year follow-up time, given that we were interested in looking at survival in this study. And so what you're looking at here in this table is the breakdown of early onset appendix cancer patients by race and ethnicity, where you can see that 3/4 of the population is non-Hispanic white. But what you can also see here is interesting and striking patterns by histological subtype by race and ethnicity, where, for example, you can see here that approximately 1/4 of the non-Hispanic Black population is diagnosed with non-mucinous adenocarcinomas of the appendix before age 50 years, in contrast to the non-Hispanic white and Hispanic populations that have approximately 15 to 17% of cases diagnosed with non-mucinous adenocarcinomas of the appendix. You also see interesting proportions of these populations by race and ethnicity by sex. As you can see that the proportion of females is lower in the non-Hispanic Black population compared with non-Hispanic white or Hispanic individuals. And so what we really wanted to assess is whether there were differences or disparities in survival by race and ethnicity among the population of early onset appendix cancer patients. And what you're seeing here is the survival curve that looks at the survival probability over a time course of 5 years. So the lower the curve, the poorer the survival overall. And so what you can strikingly see here is that the 5-year cancer-specific survival is 77% for white patients, 79% for Hispanic individuals, and is actually 64.5% for Black individuals, which is really striking that we see this disparity persist by race and ethnicity within this population. And so when we looked at Cox proportional hazard regressions to understand some of the increase of the survival odds for cancer-specific death within this population, we see that non-Hispanic Black individuals have an increased hazard of death compared with non-Hispanic whites, even after adjusting for potential differences in age, sex, stage, surgery, and histology. And you can, of course, see that independent of these other factors, histological subtype actually does play a key role in survival among young patients with appendix cancer. So, which is just what I pointed out there. And so we also wanted to look at, we split some of this data by histological subtype as was possible, given the smaller patient population in this study. But we also actually observed striking sex-specific disparities in survival among patients with appendiceal adenocarcinomas in particular. And so I want to point that out here. Among patients diagnosed with mucinous adenocarcinomas, we actually see males have a 44% increased hazard of death compared with females. And similarly, among individuals diagnosed with non-mucinous adenocarcinomas of the appendix before age 50, we see that males have a 53% higher hazard of death in that population. We also see that the sex-specific disparities really persist between whites and blacks among individuals diagnosed with mucinous adenocarcinomas of the appendix for reasons not fully understood to date. But overall, the conclusions we can draw from this study, this is the first study of the epidemiology of appendix cancer, specifically among young individuals or those diagnosed before age 50. We see that survival after a diagnosis of early onset appendix cancer varies significantly by race or ethnicity, with non-Hispanic Black individuals having lower survival compared with non-Hispanic whites. This is particularly striking among patients with mucinous adenocarcinoma histology. And the thing I also want to point out that makes this finding striking is that we don't see this disparity persist between non-Hispanic whites and Hispanics. The survival disparity is significant between Blacks and whites. But Hispanics tend to have similar outcomes compared to non-Hispanic whites within this population. And similarly, or in addition, among patients with mucinous and non-mucinous adenocarcinomas of the appendix, we see that young men experience significantly worse survival compared with young women that warrants further study. And these findings can help inform the future discovery of risk factors and reveal health disparities and outcomes within the population of early onset appendix cancer cases that warrants further study. And so I think the question that many folks had in registration and that is constantly pressing on my mind and the mind of my team is, what do we know about the risk factors for appendix cancer? And the unfortunate answer is not as much as I wish we knew. And so there was a study performed in 2019 that used a national survey or surgery quality data set, which is retrospective, meaning patients were not prospectively enrolled or collected, but were just reviewing a retrospective data set over 2016 and 2017. And the thing I want to point out here is that they looked at predictors of appendix cancer diagnosis, specifically among patients who were undergoing appendectomy. So about 10% of cases of individuals who undergo an appendectomy, we see an incidental appendix cancer diagnosis in, but we're not the comparator group in the study is not the general population. This is a population that was already undergoing an appendectomy for unspecified reasons in this case, and that's important to contextualize and consider. But what they found in this study was that both obesity and older age was associated with an increased likelihood of appendix cancer diagnosis post-appendectomy. The age factor is not essentially too surprising, given that cancer is in part a disease associated with aging. But the finding that obesity of a BMI of 30 or greater was a predictor of cancer diagnosis among patients undergoing appendectomy was of interest and tells us that obesity may be playing a role in the development of appendix cancer, but we still don't know enough about that to even be able to make that claim. And again, we're not comparing here to population not undergoing an appendectomy or general population. The comparator group here is individuals who underwent an appendectomy. However, what was striking to us in this
and results from the study was that they observed no differences in appendiceal cancer risk, or they saw that sex and race and ethnicity were not predictors of cancer diagnosis within this population that warrants further study given the substantial heterogeneity in patterns of appendix cancer, particularly among young patients by sex and race and ethnicity as observed in the work of ours that I've shown you today. However, this really amounted to there being a need to start to discover risk factors and biomarkers of appendix cancer and take a really international based approach to this. So last year, I put in a project to the NCI, the National Cancer Institute, within the cohort consortium that is a compilation of NCI or NIH funded studies for diverse reasons that may have appendiceal cancer patients included in them. And that study was approved mid to late last year that has now established APEC, or what is called the Appendiceal Cancer Consortium. So this is a nested case control study where thus far 25 large cohort studies internationally have agreed to participate in APEC. And we've identified thus far 1,240 plus cases of appendix cancer that will then be matched 10 to 1 to individuals who are not diagnosed with any cancer within the cohort. And we'll also match appendiceal cancer cases 2 to 1 to colon and rectal tumors to be able to understand a little bit more on disease patterns and differentiation of appendix cancer from colonic tumors. However, the overall goal of APEC is really to understand the risk factors, causes, or etiologies and factors related to outcomes of appendiceal cancer overall, not just specific to early onset appendix cancer cases, but among all individuals of all ages, and utilize this knowledge to contribute to reversing the increasing disease burden by understanding what health behaviors and other factors may be attributable to this rising disease burden that we don't fully understand yet. And inform clinical, molecular, and population level features that could be contributing to appendiceal cancer disparities, including some of the ones that I have shown you. And so APEC is we're currently applying for funding to be able to support this large scale effort, but hopefully it will really be a transformative impact in the field to really understand potentially the role of diet in appendiceal carcinogenesis or risk factors for appendix cancer, obesity, family history of disease, etc., and how that may be associated in overall the appendiceal cancer trajectory. And so I want to just briefly end so that we have sufficient time for additional questions on some future research directions, particularly in the context of appendix cancer among young individuals. And that includes to explore additional molecular landscapes. I've shown you a bit of our work in the genomic landscape of early onset appendix cancer, but it's really important to consider that individuals are in 3D, and there are other molecular layers like the epigenome, transcriptome, metabolome that may also be interacting with the genome that can contribute to the development or progression of disease. And so the exploration of additional molecular landscapes will be critical to better understand this emerging distinct disease biology in this population. And we also have beginning to start laboratory-based studies of appendix cancer and specifically early onset appendix cancer. I think this was also mentioned in the questions, but the study of Lamin and Hammonds as well as PMP among young individuals is lacking at this point. We are working to try and fill that gap. However, population-based cancer registries like SEER currently do not consistently collect information on Lamins or Hammonds because they're not considered to be malignant, and nor is information on PMP collected at this time in these registries. And so being able to, we're actively working to consider
the potential for inclusion. But being able to conduct studies and understand the specific PMP burden, specifically among young individuals, will be necessary. And lastly, essentially, what APEX seeks to do, there's a need to characterize risk factors, etiologies, and factors related to outcomes of appendix cancer, and what may be contributing to some of these disparities using a consortium-based approach. So with that, I want to acknowledge my entire lab and team, from undergraduates to med students, particularly highlighting, I've highlighted in this talk some of the work that my brilliant med student, Tim Gibbs, has led the charge on. And this certainly wouldn't be possible without incredible collaborators across Vanderbilt and collaborating institutions. The work to date wouldn't be possible without generous funding from both the NIH and the American Cancer Society, as well as Vanderbilt. And of course, I'd like to take a minute to shout out to the ACPMP Research Foundation, from Lauren, Susan, Carolyn to Deb. First of all, I really appreciate the invitation to come speak with you about our work, and also for coordinating and putting all the work behind the webinar to make this happen. And so with that, I am happy to take any questions. I encourage them and hope you won't shy away from asking, and look forward to an interesting discussion in the last kind of segment of the webinar.
Great. Thank you very much, Dr. Holowatyj. Great presentation. We do have lots of questions. We have 10 minutes left. If we run over by 5 minutes or so, would that be okay with you?
Absolutely.
Thank you. So all of your research and your summary about the kind of what you're seeing in the tumor mutation world is all very interesting. And we at ACPMP get this question a lot. So do you have thoughts on kind of how patients that are interested can get genomic sequencing done? So, we have some patients that go to some of the outside vendors like Foundation One, or Caris or something like that. But the fact of the matter is many patients don't realize that that is an option and that that's important for them to have that type of testing done so that they can maybe explore clinical trials or targeted therapies in addition to contributing to important research like what you're doing. So do you have any advice on how a patient that's getting ready to go in for surgery, say, or some sort of biopsy, how could they arrange for that?
Yeah, so I think for me, I always say that the patient is truly the best advocate at this point. I think being informed, and when having that conversation with an individual provider, asking about the possibility or when this can be done. I think one of the challenges that makes the study of appendix cancer unique is that often with the incidental diagnosis or finding of a tumor on routine appendectomy, at times, patients may have an appendectomy done at one hospital or institution and then may end up seeking subsequent care at a different institution. And so having access to that tumor specimen to be able to do genomic sequencing will also be important. And I think really being an advocate and seeing what the potential is at your individual institution to have genomic sequencing performed, to see if there's a potential for genetic testing, if there's a family history of disease, and whatnot, will be critical. I think once additional data in this space emerges and we begin to understand a bit more on the etiologies and risk factors associated with disease, there will be an increased awareness of appendiceal cancer and the unique disease burden overall. I think given that its rarity and that it is understudied relative to other malignancies, I think that patients and having the provider be well versed in this malignancy type and whatnot will be also critical.
Yeah, that's really good. So maybe as part of the early consultation, although it's tough because there's so much going on in a patient and family's mind, but be upfront maybe with that provider and say, look, I'm going to want genomic sequencing. And so please make sure that whatever you do with my tumor tissue, you reserve enough that should it be necessary, I, the patient, can then have some sufficient sample to send out.
And that can be challenging because the pathology needs to be confirmed, and that's ultimately the first priority, is that the tissue goes
Right.
to anatomic pathology and is confirmed. And I certainly don't want to make any, um, strong statements on this. I think it's an individual discussion between the patient and the provider of what's available, what can be done in that context, what may be appropriate for that individual case and diagnosis. But I think the patient is their best advocate at that point as well.
No, that's really helpful. And then fortunately, there are also some good clinical trials going on that will provide that testing for free as part of the trial. I know Target Cancer Foundation has a track trial, NCI has its match trial, and there are a couple others. So ACPMP Research Foundation is always happy to answer questions about those too, because we have received several just in the past few days. So that's all very good, very helpful. Now, the next set of questions is about the kind of misclassification between appendix cancer and colon cancer, and wonder if you have thoughts about that. What is going on? As you well know, many treatments right now for appendix cancer are really working off of the colon cancer platform, which may or may not be the best thing in the appendiceal world. So what is that misclassification about?
Yeah, so in terms of what you're referring to, appendix cancer cases often get included in right-sided colon tumors or grouped in such a way. And that's partly due to the fact that current NCCN guidelines recommend that someone with an appendiceal cancer malignancy be treated after surgery as a right-sided, as a patient with a right-sided colon tumor. And that's partly due to the lack of specific therapies developed for appendix cancer patients at this present time. However, the way that some of the staging is classified, it's easy to group appendix cancers in with tumors of sequel origin or that right-sided colon. It's often been done in a lot of studies. In my early studies, it was included in a right-sided colon tumor there, but evidence is emerging to suggest that appendix cancer harbors a distinct biology from right-sided colon tumors and from colorectal cancer overall. So I think there's a real need to address the potential misclassification of appendiceal malignancies versus right-sided colon tumors in order to truly help advance research in this space and better understand the specific burden of appendix cancer, given this emerging evidence that they are two distinct diseases overall.
Yeah, and possibly even, I think you touched on this, but with mutations and the significance or not of the mutations. For example, we have some appendix cancer patients with a BRAF mutation and automatically think, oh no, this is horrible, because they look at the Beacon study or something else about BRAF and colon. But I think that probably we really don't know what significance or not some of these mutations are, an appendix versus colon, right? I mean,
Yeah, and I do want to address, because we got some questions, and I think the one really touched me. And I understand how scary a diagnosis like this can be, but I think with the incredible work that the ACPMP Research Foundation is doing, and with the ongoing research, it shows hope and promise and a really strong supportive network of individuals to kind of help you not just survive that cancer diagnosis, but not survive, but thrive. And that's always kind of, they're really thrivers, not essentially just survivors on my team when we work with patients. And I think that's really important to address, is the humanistic aspect of this disease and how it touches individual lives overall.
We really appreciate that dearly. So I have to check my time. I don't want to take, okay, 2:58. Yay, we have 7 minutes.
Sure. Let me take
So,
questions from the Q&A that I think I'm okay with answering. I will be very direct in saying I do shy away from discussing individual treatment recommendations, as I feel um, without sufficient information that should be kept between the patient and the provider who knows all of the patient history and background. There's an interesting question, although I'm a little confused about any studies to indicate improved survival rates in early onset appendix cancer. Improved compared to what? It mentions about the survival rates for stage 4 malignancies. And of course, with advances in medicine, we're always trying to improve that. But if I think we need a little more clarity on improved survival rates. We have not compared survival outcomes between early onset appendix cancer cases to late onset cases. I am a little dissuaded from doing that using a population-based cancer registry because I think there's so many factors like comorbidities or other factors that may contribute to these survival differences given the stark differences in age groups that we haven't done that comparison yet. It would be interesting to explore, but I think each case should be considered individually, and treatments are, of course, seeking to help improve patient outcomes overall there. And then the question of including family history of early diagnosed cancers, including colon and breast. I think in any study, if that's possible, it would be interesting to discern diagnosis at earlier ages. I think what is equally as important a factor is the extent of family history. Is that family history of cancers, including colon, breast, and maybe pancreatic? Is that in a first degree relative? Is that in a second degree relative? Are there numerous first degree relatives that have a marked family history of these cancers? And in addition to whether they were diagnosed at an earlier age versus age 50 years and older will be important. Did truly, especially in such a large consortium based study where the data is not always collected uniformly because we're merging data across 25 plus individual cohorts, that level of granularity may not be available at this time. But I do think if the opportunity and sufficient robust data is available, that will be an important factor to look at.
okay. Good. So just back to lifestyle, because we do get a lot of lifestyle questions and you touched on some of this, but question for you on for example, the obesity factor and what you're finding in appendix cancer. So I understand that was the comparator there were those undergoing an appendectomy. Do you have any information or data on how obesity is a risk factor for appendix cancer might compare to other cancers? I mean, do we really know, or is it just obesity is not a good thing and put you at risk probably generally for all kinds of cancers and other problems?
Yeah, sure. So obesity is associated convincingly with 13 different types of cancer to date, and there's mild or limited evidence for 16 different cancers to date. And over time, obesity is projected to actually outrank tobacco use as the #1 leading cause of cancer. So I think the obesity epidemic, which is a global epidemic, is a realistic and important factor to consider. Um, Energy balance, which is the compilation of energy intake and expenditure, essentially diet and physical activity, which an imbalance of leads to obesity, has been implicated in gastrointestinal cancer risk mechanisms and outcomes for various cancer types. We published a Nature Review Gastroenterology and Hepatology article in, I believe, 2018, summarizing some of that. So I would refer to that article for additional information overall on the role obesity and energy balance play in gastrointestinal cancer carcinogenesis. However, the evidence for specifically for appendix cancer is too limited to be able to make any claims on the role of obesity as a risk factor for appendix cancer thus far. Hopefully, APEC will certainly seek to investigate the potential role that obesity plays in appendix cancer risk, as well as potentially outcomes. But thus far, I think that that evidence is insufficient.
Great. And then Dr. Holowatyj, I know we're over time, just two quick questions. I don't know if, and I know you said you would be candid, so I'm not sure if you want to take these up. I know each individual patient, has their own set of circumstances and they really need to seek their counsel from their physicians. But one question that came in is about kind of the role of systemic chemo and the effects of that. Is it advisable, is it not? I don't mean to answer for you, but I assume the answer is that dreaded answer. I'm a lawyer. Nobody likes when lawyers say this, but it depends. And I would assume that it depends, but I don't know if you have any thoughts about that.
I can't comment on
Yeah.
that in this case comfortably. I think that these treatments carry side effects, but I think they're designed to improve patient outcomes and survival. Sometimes not all patients harbor the same benefit as you kind of start to see in precision medicine, where we're trying to target specific populations that may or may not harbor a mutation for therapies in the era of precision medicine. But I defer to your provider at that point to have that discussion with them. I think there's a lot of factors that go into systemic chemo: the regimen, the length of treatment, the dose given. It's again a multifactorial consideration, the tolerance for the treatment, etc. And so it's not a one size fits all answer.
Yeah, great. And then final question, because we get this one a lot. And again, I don't know if you're the right person for the question, if you have thoughts, but for those that have undergone, particularly those that have undergone CRS HIPEC, and that have bowel issues, longstanding bowel issues, digestive issues, do you have any thoughts on diet choices, like what to stay away from, what might help, like nutritional supplements, all of that stuff?
So I do have studies on the role of emerging on folate and different vitamin levels and the association with colorectal cancer outcomes. I think that area of research is still emerging to better understand. I will always recommend a balanced, healthy diet and physical activity versus inactivity, especially during a pandemic when that may be an issue of sitting at your computer longer, staying inside. I will always recommend that healthy lifestyle and balanced diet overall, because I think that is uniform. But that's, I think, the extent to which I will answer that question. However, I think I'm watching the Q&A, and I think there was a great question that came up that asked, in my study published in gastroenterology with the survival, how do you take into consideration the improvements in treatment modalities in the study presented? And so that's partly why we limited the study from 2000 onward, is understanding that any study over a larger length of time, you could run into potential, advances in treatment modalities that could influence survival outcomes. aside from primary surgical resection of the tumor, SEER does not publicly release data on chemotherapy and radiation therapy due to the fact that it's not fully captured in the data set. And so we were unable to take those treatment modalities into consideration in that study, just due to the inherent limitations of the data set we used. I think it will be important. You run kind of a risk benefit or plus minus approach. If using study at a single institutional level will give me additional data, but the patient population will grow so small that you run into challenges to be able to have meaningful results or be able to stratify and look at some of these different factors overall. And using a larger population-based data set, you're able to, collect data from thousands of patients. However, the granularity and individual level of that data it becomes more limited. And in terms of the articles that I'm referencing, that I think that was another question of where you can find them. I think we can send the links or the articles. I'm happy to send to Deb and ACPMP Research Foundation staff to make those available for reading, as I certainly welcome that overall. And I do think there's a potential for misdiagnosis of appendix cancer based on other symptoms. We don't really understand that quite yet. I see it a lot in young colorectal cancer patients where their symptoms are misclassified or not considered, and it turns out to be a cancer diagnosis. I think, again, that's where being your own advocate is an important factor. And I also think that's where provider education can come in, and kind of awareness overall for gastroenterologists alike, for primary care providers, to recognize that this isn't a disease that only occurs necessarily in older individuals, but to retain the potential for an appendix cancer diagnosis in the differential based on some of the symptoms will be important. But of course, that's a long-term goal, and will take some additional steps to really help with that provider outreach aspect overall.
And that's why everything that you're doing is so, so important and so much appreciated. I know we're way over time, so unless you had any specific other kind of questions that you wanted to take up or comments that you wanted to make, I really want to respect your time. I know it's precious.
I don't know. It's really my pleasure. I think it's important to not only publish these studies, but it's important to disseminate and discuss them so folks are able to understand them and discern key takeaways, and truly know that we are doing our best. When we created this field of early onset appendix cancer last year, I truly wasn't sure where this would kind of lead. And I think that, that inherent curiosity and the results that we saw in our initial studies have truly culminated in the creation of APEC, which I hope will be a phenomenal next step in our understanding of risk factors and potential early detection and prevention, and how we can tailor some of that specifically to the population of appendix cancer patients.
Awesome. Awesome. That's great. What a high note to end on. Thank you so, so much, Dr. Holowatyj. Really appreciate it.
And thank you for having me. And my contact information is there as well. I really appreciate everyone joining in and for their time, and hope everyone continues to stay safe and healthy during this time.
Great. Thank you. Bye-bye.